So, again, refer to this for double contrast. Entire large intestine should be demonstrated. Transfer colon filled with barium. This is referring to this, not that picture, okay? That's single contrast. This here is referring to this double contrast. Transverse colon filled with barium. No rotation, optimal exposure. When you make the exposure, are there any type of breathing instructions? What are we telling our patient to do when we're shooting that picture?
Just don't breathe?
Just hold your breath, okay? Your book is any abdominal film, any films that you take of the abdomen. The proper instruction is take a deep breath in, blow it out, and hold it. And your exposure is done on expiration. So that's what your book tells you, okay? I just tell my patient to hold their breath. Don't move, don't breathe, click. But your book says do it on expiration. Breath hold, okay? What is our SID?
40.
40 inches. So your SID is going to be at 40 inches. It's going to be 40 inches on all your images with some exceptions that I will talk about here in just a moment. RAO. RAO is a 35 to 45 degree rotation. Check on the protocols of your hospital. They either want it centered at the crest, or if they were looking more at the flexures, they're going to have you center up a little higher. Okay? Because you may not be able to get all the intestines, the large intestines, in the 14 by 17. So if they're focusing more on the flexures, they may have you center up a little higher. Okay? 35 to 45 degree rotation. Okay. Center at the iliac crest if it's lower instead of the higher, and then slightly to the left of the mid-sagittal plane. What this means here, okay, so those are the coordinates, but when you're taking the x-ray, just put the light in the middle of the field. They're rotated, just put your frame in the middle of their backside, and look that it's even on both sides. Does that make sense? Put your frame in the middle of the body, okay? And don't center to where the belly is, okay? Don't be fooled by the pannus. You will get large patients. Don't center over here, because the intestines, they're again attached to the abdominal wall, is still going to be central to the patient. I've seen techs do this where they see the belly hanging out and they're centering way over here. I'm like, what are you doing? You're going to cut off the anatomy. Everything is still centralized. It doesn't move. So stay in the middle of the patient. Okay? All right, so REO. Here's an REO. In an REO, same thing as an LPO. Remember, aerial. REO and LPO are mirrors of each other. So the criteria for REO is very similar to the LPO, in that the right colic flexure is going to be demonstrated. That's your hepatic. The hepatic flexure is going to be demonstrated. The ascending and sigmoid colon are going to be open. Okay, so that's your REO. This is this again. So if we look back over here, okay, so REO is the same thing as, what do we say?
LPO.
LPO. Okay, your right hepatic flexure is demonstrated. See that? Mm-hmm. This demonstrates this in REO or LPO. All right. And it says here, the entire large intestine and also the ascending and sigmoid colon are open. The ascending and the sigmoid is open. Ascending and sigmoid colon are open. The ascending and the sigmoid are open. Ascending, sigmoid. Okay? All right. Again, take a deep breath in, blow it out, hold it. LAO. So we're doing the opposite oblique now. So 35 to 45 degree obliquity, center right to the iliac crest, or again, if we're looking at the flexure center up a little bit higher, and it says just right to the mid-sagittal plane. Again, just get your light field right in the middle of the body. And look that it's even on both sides. Okay? So now we're doing LAO. Looks like that. There's your LAO. Let's pull up my... So now LAO is the same thing as what? RPO. So let's get our patient in RPO position. There you go. Okay? So now what's demonstrated?
Flexure.
Which flexure?
Splenic.
Okay, so we have the splenic flexure. So left colic or splenic flexure is demonstrated with the descending colon. Okay? Splenic with the descending demonstrated. Okay? LPO and RPO we just did, so same thing. Oh, in position, we were doing the posterior oblique. I was showing you in the images. Okay, so our LPO and RPO, 35 to 45 degree obliquity, center at the crest, or again higher if we want to look at the flexures, and then center to the elevated side, just slightly to the elevated side. Okay, on the obliques. All right, so LPO, just like the REO, the right colic flexure is demonstrated, as well as the ascending, and then the rectosigmoid area, and then the RPO, which is like the LAO, the left colic flexure is demonstrated with the descending. Any questions? Okay, lateral and ventral decubitus. What we're doing here is we are looking at the rectosigmoid area. This isn't of the abdomen, but of the rectosigmoid area, the lateral or ventral decubitus. Okay. Are there any directions here? No directions. Okay. So, patients in a true lateral with a vertical beam. Okay. This lateral recumbent position is done for single contrast. This is for single contrast. A ventral decubitus is a lateral projection. Okay, remember decubitus means what?
Horizontal beam.
Horizontal beam. Okay, so it's a horizontal beam. So they're on their belly, ventral. Decubitus signifies a horizontal beam. And this is done for double contrast study. Central ray. Well, first of all, when you place your cassette, so when you place a cassette like that, what I usually do is I place the bottom of the film, usually at the level of their crease of their butt cheek, the bottom crease. So bottom of the cassette is usually right there, because you see how the light is? It's right there at the bottom of their butt cheek. Okay? Or if you want to do it that way, you can do it the central, direct the central level of the central ray at the level of the as-is and the mid-axillary plane. So level of the as-is and mid-axillary plane, so you can do it that way too. Okay, so lateral recumbent, single. Ventral decubitus, double contrast. Using a small image receptor, 10 by 12, 11 by 14 is going to be your field of collimation. You don't need a lot. Now, as you're moving your patient around, rolling them around, you're also going to assist them because you don't want them accidentally getting caught up on the tubing and then it gets pulled out. So you're not just telling them to move, you're going to assist them in moving. Okay. So the erectosigmoid region is demonstrated with no rotation. So again, this is single contrast. Okay, single contrast. And then we have here double contrast, ventral decubitus. So this here is ideal for looking in the area between the rectum and the bladder or uterus. They're both good for looking at that area, but the double contrast study is especially good for this. So ideal for looking for any type of anomalies, polyps or diverticula in that region. And you guys notice this double contrast, right? Because you see the fluid level. Fluid level versus the air level. And you guys are familiar with doing this, right? Decubitus, you guys should know how to do this by now, right? All right. So they're going to be laying, again, they're going to be laying on their right side or left side. They show different things. Just get the central ray and the image receptor at the level of the crest. If you want to look at again, the flexures, you may have to center up a little bit higher. Check with your doctor how they like it. Now this is going to be best for polyp detection on the upside internal lining of the bowel. What that means is, here we have somebody on their left side, left lateral decubitus. So
It says right.
on upside internal lining, yeah, okay. So what that means here is they're on a decubitus over here, right? So we can't see polyps here because it's full of barium, but we can see polyps up here. So we're looking at the polyps at the inside lining of the upside. Inside lining of the upside. So same thing down here with the ascending, you can't see the lower side because it's full of barium, but you will see the upward lining of it to look at polyps, which are inward projections or in-pouching. Okay, so best for polyp detection on upside internal lining of the bowel. Does that make sense? Yeah? Okay. Right? Because, again, let me just go back over here. Because if they had polyps, you can see the polyps in here because it's full of barium, right? But you can see the polyps up here, right? So inside lining of the upside, you can't see it in here because it's full of barium. Same thing here. If you have polyps inside here, you can't see it because it's full of barium, but you can see the ones on the opposite wall. Okay?
Mm-hmm.
Some places will have you use a wedge filter. Do you guys remember that? What a wedge filter is? You guys know what a wedge filter is? Okay, so if you had a wedge filter, where would you put the thickest part of the wedge?
On the thinner part of the body. Front of the thinner
Okay,
part
so
of the
thinner
body.
part of the wedge you would place where?
On where a thicker part of the body is, in front of it.
Okay, well, we're talking about contrast here now, so where would you put the thicker part of the wedge?
Lower the arrows.
Towards the bottom?
Towards the bottom. So it's not about thicker, thinnest part.
It's where barium is.
Yeah, you're not
barium
talking about the
is.
thickness of the patient now. You're
Yeah.
talking about what is it that you're trying to penetrate, which is
Okay.
barium. So the thicker part is going to be right here.
On the downside
Yeah.
of the patient and there.
I'm sorry, the thin part. This is where you put the thin part of the wedge. Thin part of the wedge here because you want more penetration, extra penetration. Okay, and a thin part of the wedge, a thick part of the wedge up here. Okay, because all the contrast can be down here on the downside.
What about that contrast that on the upside too?
We're
and
gonna get
that's
it on the opposite
Okay.
decubitus. Yeah, we'll get it on the opposite decubitus. Okay. And then left lateral decube, again, center at the crest or a little higher. Now, remember I told you that most of your SID are 40 inches. Okay? And I say you may have to center up a little bit. This is only applies to the decubitus. That you may have to center up a little bit higher to get the flexures. You will see your technologist doing their decubitus at a minimum of 60 to 72 inches. What happens when I'm increasing my SID? Yes, but what else?
decrease exposure.
No.
No?
I mean,
Okay,
okay, yes,
it
yes,
is.
yes, decrease, okay. But
less magnification.
less magnification. So if we're trying to get the entire bowel into that film or that image receptor, we can do that by increasing our distance, because when you increase SID, you're decreasing magnification. So you will see some technologists shooting their decubes at about 60 to 72 inches instead of the 40. We're actually all good answers, guys. All right. Are we almost done? How many more?
Too many.
9? How can it be 9? There's only like
We should
2
have gone
minutes
for a
left.
break. That's it.
Extra slides?
They keep popping up.
All right.
And-
Okay, the next one here is called an apiaxial, or an apiaxial with an oblique position. And this is to demonstrate the rectosigmoid section. So again, it can be done in 2 ways. So here is an apiaxial 30 to 40 degree angulation cephalad towards the head. You're going to center 2 inches inferior, so here is your as is. You're going to center 2 inches inferior, so right about here at this level, inferior the as is, and to the mid-sagittal plane. Now the alternate for this is the LPO with the angulation. And so with an LPO, you're going to rotate them about 30 to 40 degrees. And then at that level of the as, 2 inches below the level of as is, you're going to go now 2 inches medial to that as is. So 2 inches inferior and 2 inches medial to that right as is. And again, it's for the rectosigmoid area, and it's going to look something like this. Okay? So we do an LPO because if you look over here at the apiaxial, this area here is still kind of superimposed and a little convoluted. When you do an oblique LPO, it opens up this area a lot better. And they call this, you'll hear your techs and your doctors call this the butterfly view. And that's why I'm staring at this, because I can't see a butterfly.
On the left, you can.
You can?
Yes. Right there. Do you want me to show you? No, you're looking at the wrong place.
That's not it?
No. Wait, right here.
Huh?
Rotate that 90 degrees. are right here on the bone.
Oh, we're not looking at the sigmoid. You're looking at the butterfly. Oh, you're looking at
Here,
this.
her wings.
That's why it's called butterfly. Okay. Yes. That's
Yes.
why. Okay. You know what? You're right, because I had the same student show that to me. Another student showed that to me last year, and I keep focusing on this and not this. That's why it's called the butterfly view, because of the.
So, but it's called not for the oblique one, only for the one on the left, right? I mean, you can't see
They
them.
still call it butterfly.
They still call it?
Yeah.
I can't see them on the
Well,
oblique.
you're not, but they still call it that. But you know the so the difference is you open up the sigmoid area on the LPO. Okay, and then this is the opposite. So you're now doing PA. PA, so it's the opposite direction, 35 to 45 degrees. I'm sorry, 30 to 40. Central ray at the level of the as is. In other words, you can't see the as is here, but you can feel for it down here, so it's exiting the level of the as is. And then mid-sagittal plane. And then up there, you're going to be at the level of the as is, and here's the level of the as is. Okay? But you're going to go 2 inches slightly to the left of the spine on an RAO. Reverse butterfly.
How many more butterflies? Reverse, inverse.
Yeah. All right, so here we also have elongation of the rectosigmoid colon. If you do the oblique, it does open up that region a little bit more. And then lastly, once you're done with your overheads, this is the last part now that you're going to do. You're going to have them roll on their side. Okay? You're going to have them roll on their side. You follow? We're just about here to finish here. So we're going to have them roll on their side. We're going to take the tip out. What do you got to make sure first? Deflate the balloon. So deflate the balloon. Okay? Am I missing a step? There's instructions. Yes, I'm missing a step. All right. I'm going to rewind a little bit. So before you remove the tip, now this is where the trash can comes in. You get your trash can. Just have it near you. Okay? But before you remove the tip, you are going to unclamp this. The tip is still inside. Okay? You're going to unclamp the drain, the tube. You're going to drop the bag, because now what are we allowing to do? We're draining the contrast out of the patient's bowel. Okay? And so this is what's going to happen. As you're watching the bag, you're going to see it going, making a whole bunch of sounds, and you're going to see bubbles coming out, as well as the barium. What's the bubbles?
It's his dog.
It's your dog. Is that the name of your dog?
Yeah.
She's coming out of the bag.
That's cute. Okay, so now the barium's draining, okay? And we're gonna just watch it drain, and then when it stops draining, now we are going to
Deflate.
deflate the balloon, okay? And you're gonna have a towel ready, okay? You're gonna take the towel, you're gonna rest it right up on top of their bottom, okay? And then you're gonna say, breath in, breath out, okay? And that's where the trash can comes in. Now you're gonna just dump everything in the trash can, okay? And so the towel is making sure there's no residual coming out, and you are also wiping any excess jelly from the lubrication. So you're gonna clean them up a little bit. Okay, so you're gonna clean them up. Then what you're going to do is you're going to sit them up, okay, and we're going to have them walk to the restroom. Okay? But before we have them walk, what are we going to do? Okay. We're going to have them sit there for a little bit, because if you've lain there for a long period of time, remember that orthostatic hypotension. Okay, if they get up too quickly and they start walking, okay, the room will spin. Okay, so have them sit there for just a little bit before you have them get up. And then you're going to escort them to the bathroom. You're not going to let them walk by themselves. You're going to escort them, because they may be having some liquid falling out and they're going to slip on it, and now they fall, and now you have liability. Okay, so you're going to escort them to the restroom. All right? And then assist them on the commode, and then you leave. And you say, I'll be out here. Go ahead and go to the restroom, relieve yourself. I'm going to be out here. Okay, when you're all done, come on out. All right? Now, for first-timers, if you've ever heard anybody go to the bathroom after they've had all this air pumped up in them, it sounds like the 4th of July. The first couple of times I'm like this. And after that, it's like, you know, you get used to it. Okay? So then they'll come out. Now you're going to put them back on the table, and you're going to do your post-evac. It's called the post-evac. After they've emptied, okay, you're going to do a post-evac KUV, and it's usually done in PA for the same reason why we always do PA, is to kind of spread the bowels around, acts as a compression. But can we also do it in AP? Yes, we can. Yes, we can. Okay. So that's your post-evac. All right? Oh, instructions are here. All right, you got this, right? We got it. Ta-da! Okay. Next week we have a quiz on small bowel and lower GI. But as a reminder, guys, there is no lab Monday and Tuesday. Okay? No lab Monday and Tuesday. You guys all right?
Yay!
Okay. All right.